disorder. I'll let Andrea introduce herself.
Hi, I'm Andrea Logan, pediatric nurse practitioner. I have been with the eating disorder program in Relay of Soldiers now for the last 3 years, and we work as a collaborative team, and we're happy to be here to present to you today.
So we're happy to take questions in the chat during the presentation, and then we'll try to get to as many as we can along the way. And if not, then we'll answer any questions at the end. We left a lot of time for that. So today we're going to be talking about the eating disorder shadow pandemic that's occurred during COVID-19 and has been fairly significant. This is something we've been noticing in our hospital, but it's also been occurring around the world. So we thought with that, we've seen a real influx in referrals from everywhere. We know everyone's been struggling with how to manage these patients. So we're going to talk a bit about that today. And just click my next slide. So we have our learning objectives for the presentation, which I think were sent out in advance. So we want you to be able to understand the prevalence, demographics, morbidity, and mortality of eating disorders in children, how COVID-19 has changed that, how you can identify red flags for eating disorders, and how they're different than in adults. And understanding our referral process, because we're the main regional program. So if you do have patients who have eating disorders, they will likely come to us. And then knowing what the role of the primary care provider is in treating children and adolescents with eating disorders. So that would be nurse practitioner, family physician, ER practitioner, anyone who's seeing them before they reach specialist care. So this is the order of things we're going to go in. We're going to talk a bit about why we think this is important in the background of eating disorders. And we're going to, again, like I said, talk about how COVID-19 has changed that a little bit. We'll go over what the common eating disorders are for kids, because they're a little different than adults. Talk about how a primary care provider would assess an eating disorder patient, how to refer, what to do while they're waiting for a referral, because our wait lists are quite long at the moment, and some community resources you can access. And then we'll go through a case study to give you an idea of how these disorders present and some of the things to look out for. All right.
So we just wanted to start by giving a little bit of background on why this is so important to recognize and appropriately manage eating disorders. And I just wanted to start with 2 quotes. One is from the National Initiative of Eating Disorders, and it says, "Eating disorders are misunderstood, inadequately treated, underfunded, devastating to deal with, and the deadliest of all mental illnesses." And I think it's really important to kind of put that summary right at the front, to know that when you're having frustrations maybe, or we're having frustrations that we can't get kids in as fast as we want, what resource can we use next? This is not just here, it is everywhere. We just recently had a mom write our program to tell us how much she felt support had helped, how much they are finally on their way to recovery. And she actually wrote this to the MP and gave us permission to share this. "As a mother, I must tell you, they have saved my life too. When you are navigating this disease on your own while fearing the worst every single second of every single day since you found your daughter on the bathroom floor with cuts all over her body from her own attempts to make the voice of the eating disorder a bit dimmer, it wears on you. It consumes you too, but you know you can't give up the fight for your child's life." And that really reflects a lot of our parents when they get to us and where they're at. So eating disorders are a mental health illness, and they have multiple physical consequences affecting every organ in the system, regardless of weight. So we can have kids who plot normal on the growth charts, they can have a normal weight, but the problem is that what we're missing is that they lost 40 pounds in the last 3 months. So again, always remembering in that contextual when you're looking at them, weight is but one of many different factors that diagnose an eating disorder. For this reason, eating disorders can be very difficult to diagnose, as they are very complex, and they require multidisciplinary specialized teams to really support all the different aspects that come along with an eating disorder and to allow for best long-term outcomes and hopefully recovery. Eating disorders don't choose to only affect certain genders, ages, sexual orientations. They affect everyone. They affect everyone from different ethnic identities, social economical status, sexual orientations, to gender, to ages. So there's multiple factors that can assist in the development of an eating disorder. biological, social, personality, psychological. Social media has become a very big aspect, and we will talk to that more as we go on. Patients don't choose to have an eating disorder. It's really important to realize that it's not a lifestyle change. This is more than that. So the most common eating disorders that we find in pediatrics is anorexia nervosa, restrictive subtype, and binge purge subtype. Avoidant restrictive food intake disorder, or as better known, ARFID. Other specified feeding and eating disorders, better known as OSFED. A lot of people, when they refer to us, will say, I'm really concerned about this child. They're having what I think is bulimia nervosa. So that is more identified in the transitional youth, so 18 to 25, and the adults. In children and in the pediatric realm, it is more anorexia nervosa restrictive subtype with binge purge subtype. So oftentimes it's not a true bulimia, and we'll get into that again too as we move forward. There are multiple factors or etiological factors that affect, and I kind of already addressed those, so I'm not really going to go into them again, but as we stated, social media is a big one right now. So the shadow pandemic and why it's being called a shadow pandemic, to give you a big picture, just even up here and really Soldiers Memorial Hospital, we have noticed that younger Canadians are also increasing and engaging in dieting behaviors. It's putting them at risk of developing a full-blown eating disorder. And even if they aren't meeting DSM-5 criteria for an eating disorder, that doesn't mean that they don't have some disordered eating that is compromising their health. So 300% increase in referrals and admissions over the past year at Aurelia Soldiers Memorial alone. Normally, on average, we would admit 11 kids, 10 or 11 kids a year. And since January of 2021, we have admitted over 50 children with eating disorders. As they're coming in, we're noting more complexity. They are more medically fragile than previously, and they have more medical comorbidities coming in. Our current stats show an age group of 10 years up to 18 years of age, and we're starting to see a much younger patient population, so specifically that 10 to 12 year range. Just briefly to give you a little bit of background about pre-COVID stats, 12 to 30% of females and 9 to 25% of males aged 10 to 14 had reported dieting to lose weight. It will be really interesting to see what stats come out from the COVID pandemic, because there just hasn't been time from anyone to really do the research, because every single program is over inundated right now. The incidence of eating disorders in children pre-COVID was 2 to 4 times greater than someone with type 2 diabetes mellitus in the same age group. And although we see anorexia nervosa usually being the most medically compromised when we meet them, as I said, we can have equally unstable children without meeting DSM-5 criteria. So some of the increased issues, some of the issues that have led to the increase is increased social isolation and related mental health problems. So maybe children who had previously had some slight anxiety or depression or been a little more prone to that, now really experiencing a lot more because they've been socially isolated. They've lost their activities. They've had changes in their eating habits. So a lot of them are home, so they were eating more and noticing that they were gaining weight. Other ones were competitive athletes, no longer allowed to do their sports. And so they were eating more or the same as they were before, but they didn't have the activity level that they did anymore. And so they started training at home, trying to make up. There was even some schools where some of the teenagers had groups going to see who could lose the most weight. TikTok videos going around of who could do the best exercises and the best dieting habits. So that increased social media presence was really, really viewed. The biggest thing that we've noted is fewer eyes are on these kids. So we've had virtual medical visits in the community. We've had virtual schooling. So we've had less contact in general with coaches that would normally notice something happening earlier on, teachers who would normally notice, or guidance counselors, as well as our own teams, our own healthcare providers. We can't really see an eating disorder over virtual. That is one thing we have noted. At the starting of the pandemic, we were trying to do virtual appointments, and very quickly we realized that virtual wasn't going to work for our population, and we had to get permissions to see our patients in person because the secrecy of the disease, it was like loving this, because all of a sudden it was secrecy and isolation, and they were just thriving. Parents were at work, they were alone in the house, they could do what they needed to do. And going on to video, they could wear their baggy clothes and cover up and look okay from the head down. And so unfortunately, one of the biggest things we've noticed is there's been a minimal increase in resources, not just at Aurelia Soldiers, but across the province and internationally, to match the needs of this shadow pandemic.
Okay, so now I'm going to go through, I know a lot of you probably know about the common eating disorders, but we're going to go through the DSM criteria quickly and sort of compare and contrast them and talk about how that might look in kids and adolescents. So first of all, anorexia nervosa. So the main criteria, the first criteria is restriction of energy intake relative to requirements, leading to significant low body weight. Now we say low body weight, however, that's not necessarily true. It can be just a significant amount of weight loss in a short period of time. Sometimes that's called atypical anorexia, but it all falls under anorexia. The primary feature of anorexia, I would say, is this intense fear of gaining weight or becoming fat, or if their child is not vocalizing this, which often if they're a little more sophisticated, they won't vocalize that fear. They will demonstrate persistent behavior that is preventing them from gaining weight or causing them to continually lose weight. So for example, if you have a child who insists that they're not afraid of gaining weight, but they are currently restricting their diet, eliminating foods from their diet, weighing themselves every day, certain other behaviors we'll talk about later on, that is a substitute for this intense fear of gaining weight. The second part is this disturbance in the way your body shape looks. So a perception that you look larger than you are, or a certain part of your body looks wrong. That body dysmorphia is seen in anorexia. Now we talked a little bit earlier about the different subtypes. So I would say this restricting subtype is more common. It was, but we're seeing more of the binge, more of the, I would say like a restricting purging subtype since the pandemic has started. And that is, we're seeing kids who don't necessarily have true binges or objective binges, which I'll get into during the bulimia portion, but they have these subjective binges where they eat more than their calorie goal for the day, or they eat more than they would have liked, or they eat a fear food and then they purge in compensation for that. And purging behavior can include laxatives, diuretics, enemas, vomiting, but also exercise can be included in purging. So we don't look as much at the full remission, partial remission severity, but that criteria is there if we need it. Now, bulimia, the way bulimia differs, I won't go through the criteria too much, but the way bulimia differs from anorexia nervosa binge purge subtype is there's a few ways actually. So the first way is that the binges that occur in bulimia are true objective binges, and they're defined, and the binge, as you may or may not know, is defined by eating a certain amount of food within a period of time that is far more than a 2-hour period that is definitely larger than what most individuals would eat in a similar period of time. People who are binging with bulimia or binging and binge eating disorder, for example, there's a real sense of lack of control. They're out of control. They can't stop eating or control how much they're eating. This would be, for example, eating multiple bags of chips or a whole package of cookies or more even. The binges that we see patients describe in anorexia binge purge subtype are often, I ate 2 children-sized cheeseburgers or something similar. So the amount is quite different and the feelings that go along with it are different. There is no necessity in bulimia for somebody to be underweight or for somebody to have lost weight. People with bulimia can be a typical weight, or they can have a stable weight and still be struggling. So I won't go too much more into that. Those are the main differences. They do have some issue. They do have the negative self-evaluation that's unduly influenced by body shape and weight, but it's a different disease than what we're seeing with the binge purge subtype of anorexia. Now, avoidant restrictive food intake disorder we find is a condition that a lot of people who aren't in this area don't know about necessarily. It is a feeding or eating disturbance that is manifested by persistent failure to meet appropriate nutritional and or energy needs associated with one or more of the following. So either weight loss, nutritional deficiency, dependency on enteral feeding or nutritional supplements, or marked interference with psychosocial functioning. And this can't be explained by there's not enough food available, or that it's a culturally sanctioned practice, so fasting, for example, during a religious event. And it's not associated with anorexia or bulimia. So the main difference with ARFID is that there's no association with this fear of gaining weight or undue influence of body image on the children's intake in this condition. Often there's a lot of sensory things. So for example, children have a very restrictive diet because they don't like the way things feel in their mouth, or often we see this happen secondary to a gastrointestinal illness where the child has eaten and become sick and is afraid of vomiting, or has a sensory feeling of being full that they then associate with vomiting, so they don't want to eat. And choking, yeah, is another one. So I would say in the past, this was more common in younger kids, and I think it still is, but we're seeing more younger kids with true anorexia nervosa. And sometimes this is a child will be diagnosed with ARFID, and then the thoughts about the eating disorder thoughts will come out. So the thoughts about body image and restricting will come out in the future, and so that diagnosis may change. But yeah,
there's also a higher evidence or higher incidence of going into anorexia nervosa from an ARFID diagnosis if not treated appropriately and correctly. So these kids can, as they get older, change from an ARFID diagnosis into an anorexia nervosa.
Yeah. The next one that we're seeing a lot of recently and in general is OSFED, or other specified feeding and eating disorder. Correct me if I'm wrong, Andrea, but this would have previously been under the EDNOS category, or eating disorder not otherwise specified. And so this is, we generally use this term to refer to children who have another condition that is causing them to not take in enough food or not being able to eat enough food. Technically, atypical anorexia is under this heading. But what we commonly think of as OSFED are children, for example, who have a major mental health illness that is preventing intake. So for example, children who are so anxious that they have physical symptoms of anxiety and feel like they're unable to eat. Or children who have severe disturbances like psychosis, who have unusual thoughts about food, and that's preventing them from eating. So that's where OSFED comes in. And then I just wanted to touch briefly on relative energy deficiency in sport, which we don't see that much of. Andrea was saying we've only seen one case in the past few years, but this is something that may not get to our team that frequently if it's caught early enough. So this was formerly known as, and probably lots of you know this as, the female athlete triad, which is a combination of disordered eating or insufficient energy intake, amenorrhea or oligomenorrhea, and decreased bone density, so fractures or pathologic fractures. This is what happens when you have a child or an adolescent or an older person in a high intensity sport, or who is putting out a lot of energy because of physical activity generally, and that they are simply not taking enough in to compensate for all the energy they're putting out. The main concerns in here are, nutritional deficiencies in bone density. There isn't necessarily a fear of gaining weight or a body image component here. Now, that being said, it is heavily associated with sports and activities where being lighter or leaner or like more agile, like for example, running or gymnastics.
We've had a kid who is actually a competitive hockey player with this, and I can tell you they do not want to lose weight. They do not want to, and that's a really big thing. I have to just stress though, a red flag with REDS is that we often get kids who are referred to as pre-REDS, and the older they get, as Dr. Somers already kind of identified, they're much better at being the more intellectual communicator with us, and so they're very well read on eating disorders and know what to say and what not to say. And so we've seen more so over the last year kids who are absolutely 100% not trying to lose weight, not doing this, not doing that, and they actually are a full, very sick anorexia nervosa.
Yeah, absolutely. And so this isn't a DSM diagnosis. this, and as Andrea flagged here, often this can be sort of anorexia in disguise, and the patients tend to have a similar personality type to patients with eating disorders, highly driven, very high achieving, dependent on external validation, that kind of thing, perfectionistic. And they can have similar physical symptoms to eating disorders, which we'll go over later. And then the other thing that is a red flag here is this orthorexic type behavior. So eliminating certain foods, being very conscious of macros or fats or protein, or often high protein is a really big one, low carb, that kind of thing can manifest in this. And often it happens with really well-intentioned trainers or coaches or kids trying to do their best, but it can morph into something more sinister. So it's just one to be aware of.
And the reason they changed the name is because it's not just females
Right.
who actually have this condition. It can be male or female, just like eating disorders of any DSM-5 criteria.
So this is what part of Andrea.
So eating disorder assessment for our primary care partners. One of the things I just want to highlight is normal weight does not mean a healthy weight. So we have had some situations in the past where we've had a kid come and said, well, my doctor wants me to come in and get my eating assessed, but don't worry, I don't have an eating disorder because they told me I don't have the weight loss. Or we'll have other kids who say, well, they said I was still pretty normal weight, so I've been working really hard to lose more. Because to an eating disorder, it's challenge accepted. You say I'm not sick enough, let me get myself there.
And I'm just going to jump on that. So one of the patients we actually had this year, there was a contest in their class to see who could be the most sick patient.
Yeah, we had a group of about 10 kids who were seeing who could be admitted the longest, who could be the sickest. So weight, as we've stated, doesn't always reflect severity of the illness or their psychological distortions. So even if they're coming back stabilized from a vital sign capacity and from all of the different labs and diagnostics, some of our sickest kids are actually stable, but they're the ones who end up staying with us the longest because of the psychological distortions that they have. So as I kind of already started to say, language used in an assessment is very important. They want to be the sickest. So telling them that they're not sick enough will lead them down that way. So it's really important that we don't, I actually advise you not to give them like, you're an anorexia nervosa, you're a bulimia, you're this, you're that. If you have an eating disorder, you need to be assessed by a specialized team and almost leave it in the team's time to figure that out, because it does take time. Sometimes we can be with these kids for a few appointments before we even start to suss out whether it's OSFED or AN, or because they're just so good at keeping that secrecy and they've been living with this for so long. Eating behaviors do occur on a continuum, so they don't always fit nicely into that DSM-5 criteria, but there can be significant distress, not only with the patient, but their families too, and significant damage to their physical and psychological health. So restricting quantity and quality of foods is something to pay particular attention to. Always asking, oh, how many calories do you think you should be getting in a day? You would be surprised how many times they're really open about that, especially if they're malnourished. The more malnourished they are, the one helping guide to us is that they can't think of their answers as well. And so that's when they kind of just give us everything. They will cut out foods that they used to love. So parents will always be like, well, 2 years ago, they would have eaten all of this and now they're not eating any. And it's not just in the last 2 months. It's usually like, well, a year ago, they became a vegan. 2 years ago, they became vegetarian. And then they went gluten-free, and then they went, and then they went, and then they went. So you'll start to see those patterns. So usually by the time we're diagnosing an eating disorder, it's already been entrenched for about a year or so. Excessive exercising. So we had one kid that we recently discharged who literally lived on a farm, had this really long front driveway. It was about 1 kilometer, would walk down to get the mail, but only get 1 piece of mail each time and bring it back and then go back and get the next piece of mail. And that was their excessive exercising. So they weren't, hitting the weights. They weren't doing running excessively, but that was their way of doing it. If they have a significant weight loss, especially those kids who were plotting overweight and now all of a sudden are at normal weight, but they lost it quickly. Also personality changes. So a lot of times you might get a patient in there where they're like, oh, we're concerned about our kid with depression or increasing anxiety. And it might be just that they're malnourished. And they like to isolate themselves. So ask them about who they eat with and how much they eat and how many times a day do they eat. And one of the questions I do ask parents is, are they eating 25%, 50%, or 75% of what you would eat on a plate or what you think your child should be eating on a plate? Because that can give you a really good picture too if you can't get caloric intake. Really, really concerning symptoms, because this usually means they're deteriorating, is decreased cold tolerance, dizziness, when standing or lightheadedness. Now that one's a fun one too, because if they've done their homework or they've been to a hospital already, if they know they admit to dizziness and lightheadedness, they'll get admitted, they won't admit to it. If they're talking about, oh, I just get nauseous all the time when I eat, I can't eat that, or I get nauseous when I eat pasta, I can't eat pasta anymore. I just get full too soon. Well, remembering that our bodies will acclimatize to what we're giving them. And then that impaired cognition. I can't stress how important it is to actually lay eyes on these patients. We've had multiple referrals coming in over the last year where it says, unable to assess vital signs, unable to do anything, unable to tell you because I didn't see them, this is from the parents. With the increase in numbers that we're having, trying to triage based on nothing really to give us an idea of where they're at, we are now starting to send referrals back. We have no choice, we need to, because we need that information to triage and make sure we're not missing a kid who could potentially be in cardiac compromise at home. So we've had to start sending back, and we'll talk a little bit more about our needs when you're referring. So bringing them in person, seeing really what they look like, putting them in a gown, because baggy clothes can trick you. So signs of malnutrition. So just looking at their body overall, are they cachectic? Does their hair, are they talking about hair falling out, or the hair looks thinner? Their skin will often look very pale. They may have dark seated eyes. They can have the acrocyanosis to the nails, which is a really big factor. Prolonged cap refill. They can also have, oh my gosh, I'm forgetting. Thank you, lanugo. To usually the abdomen and the arms is where they first usually note lanugo. Signs of purging.
I forgot to mention, sorry, the other side of that, edema.
Edema, yes. Oh yeah, if they have edema, that's emerge. Like, do not pass go. If there's any edema in the extremities, please just send them to emerge. That's becoming more common too that we're seeing. Signs of purging, so it's called Russell's sign. It's the sores on the knuckles. They'll have sores and they can't really, they'll be like, oh yeah, like the cat did it. And you're like, that's not a cat, that's a burn. Poor dentation, so they might have oral dental caries or oral lesions in their mouth. They'll have halitosis, and they can actually have parotid swelling, so right in here. Vital signs are so important. Orthostatic vitals tell us a lot about a kid, and it does weigh in whether or not they get admitted. So best practice guidelines right now is 5 minutes having them lie down and then doing an auscultating a heart rate and doing a blood pressure, and then having them stand for 2 minutes and repeating that. Blind weights. We do not want the children knowing their weight. The more information they have, the more they'll utilize it. So what we do here is we have them in a gown and they back onto the scale, and we do it the same way every time. So if you can't put them in a gown, like for instance, sometimes an outpatient, we have one of our scales right in the waiting room. We're not going to put them in a gown in front of everyone in the waiting room, but they do have to wear the same clothes every time. So a t-shirt and a pair of pants, or so on and so forth. Make sure that if you are letting them wear their pants, everything is out of their pockets. What is concerning and what we know happens is they will put stuff to weigh them down. They'll wear more jewelry. So all of that kind of stuff should be off. So gowns, these if you can, and a height. We cannot figure out what their ideal body weight should be without a weight and a height. And with that, I'm going to jump to the bottom there and say comparative growth chart. So a weight and a height is a one point in time, but what we really need is to see what those growth charts have been over time and how much they're dropping off, if they are, to help us identify where they should be along the continuum. ECGs, this gives us our evidence around cardiac muscle weakening, which occurs with the malnutrition. Also arrhythmias. We know one of the main causes of death in eating disorder patients is cardiac, and it usually happens at home. So sinus bradycardia is the most common that we see, and sinus bradycardia for admission criteria is under 50 when they're awake. Blood work and urinalysis, ideally get it all done at the same time. First of all, it rules out other causes. So we have had other kids come where they've had a hypothyroidism or something going on. Electrolyte imbalances, which are becoming more common with fluid overloading, purging, as well as taking supplements. One of our kids takes creatinine supplements all the time. And it also identifies whether they're using laxatives. And as I stated already, fluid overloading, even a urinalysis, specific gravity should be done at every appointment, really. And when you're doing their weights, by the way, I would get them to pee and then do their weight. Or if you do their weight and you think, oh, they went up like 4 kilos, get them to pee and do it again. So most common blood work that we need is CBC, iron studies, electrolytes, extended lights, ALP, ESR to rule out any inflammation, random glucose, urea, creatinine, AST, ALT, GGT. PTT, INR, bilirubin, albumin, which is really big for not only dehydration standards, but also for purging, and amylase as well, vitamin D, vitamin B12, and then the hormones and beta carotene. Out of those, the most important is the electrolytes, the extended light, the random glucose, followed closely by the CBC, albumin, and amylase.
Perfect. So once you've assessed a patient and you're concerned about an eating disorder, the next steps are important. And so the first thing that you need to know are what makes your patient, what makes a patient's story and examination concerning enough that they qualify for admission to the hospital. And so when we talk about this, we talk about whether or not a patient is medically stable. And so if the patient is medically unstable, then they need admission for medical stabilization, and that may include refeeding, heart rate monitoring, all sorts of different things. So at OSMH, we have admission criteria that we've worked on, and this is our admission criteria. So the tricky thing about eating disorders, which we didn't talk about yet, is there's really no gold standard for anything except for family-based therapy, which we'll talk about later. So there's no consensus on what heart rate, blood pressure, any of these things, and every center does it a little bit differently. Our center has tried to align ourselves as much as possible with the various tertiary centers and the various centers around the GTA who have eating disorder programs, but everywhere will be a little different. So the bottom line is, if you're concerned, just call the pediatrician on call at OSMH. You can call the eating disorder outpatient team, but if you think a patient needs admission, call the pediatrician on call. If your patient is in the RVH area, call the RVH pediatrician on call or contact their eating disorder team. We're happy to walk you through it at any time. We'd rather a patient come in and be assessed than have a medical event at home and have a negative outcome, which we have had happen recently, unfortunately. So the criteria for our admission, like Andrea said, a heart rate less than 50 awake, BP less than 80 systolic or 60 diastolic, any arrhythmia on ECG other than sinus bradycardia. So unless it's below 50, if it's sinus bradycardia, we're not too concerned. Any orthostatic changes, so we've defined that as heart rate change of greater than 40 from sitting to standing, lying to standing, and the blood pressure gradient of greater than 20. The heart rate is much more common. We rarely see the blood pressure gradient, but the heart rate gradient is common. Adding along with that, if there's significant symptoms associated with going from lying to standing, like Andrea said, dizziness, lightheadedness, significant pre-syncope, or syncope itself, then that would also, even if they don't meet the heart rate criteria or the orthostatic changes criteria, that would also be a reason to admit. Now, that being said, a huge number of teenage females have dizziness going from lying to standing. So that's a bit of a judgment call, but like I said, if you're worried, just call us and let us know. Now, the next one, less than 80% of progress weight or ideal body weight. So progress weight is what we set when the patient comes into the program or gets admitted to the hospital. And that's where we would ideally want the patient to end up after they've recovered or are in recovery and have gone through the initial stages of treatment. I should say stabilize. We don't expect you to calculate a progress weight or an ideal body weight. It's complicated. There's multiple different ways of doing it. But if you have a patient who's being followed by the eating disorder team and you're assessing them and you weigh them and you note that that weight has dropped below that 80th percentile, that would be a reason to call us.
You can also call us if you are concerned that you think that they're under 80% and you're not sure. Great question.
Code blue.
Sorry.
First floor, day surgery. Protected, code blue. First floor, day surgery. Protected, code blue. First floor, day surgery.
You can always reach out to our team. We're more than happy to answer those questions because it means identifying a kid who should have been admitted. And this has happened recently where we've had emails from physicians within the community or NPs, which has been great because we've been able to have that dialogue. And almost every single one of those kids were admission criteria. And I'm not talking just 79%, I'm talking they were 70, 65%. And so they were really sick. And although their vital signs were still stable, as we all know, With pediatrics, compensate, 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 crash, whereas in adults, we kind of get more. So they're at that compensate and we don't know when they're going to crash.
Yeah, absolutely. And I will say too, that we often see after patients who are very low weight, their vitals might be stable when we admit them, but after we admit them and they've been on bed rest, we find that their vital signs often become more unstable in the initial couple of days.
Yeah.
The other reason to admit or to ask for admission is acute food refusal. So if a child is not taking in anything for 24 hours and you are concerned about an eating disorder, you know, we're not talking about a child who has a gastrointestinal illness or something like that, but if in the context of an eating disorder there's acute food refusal, then that's a reason to admit for symptom interruption or stability.
One other thing with the progress rate, and another reason why we get really concerned and why we want to admit under 80% is because if they're under 80%, chances are they are severely restricting. And so once you get to severely restricting, some of the messages that I've heard kids get when they've gone to emerges, wherever they've gone, or to urgent care clinics or something, will just go home and start eating more. That's a concern because we have refeeding syndrome. And so these kids actually get into trouble and get into refeeding. And by the time they get to us, sometimes they have very abnormal electrolytes.
We used to do a lot more admission for symptom interruption, and we've been doing less of that strictly because our needs, like the needs of our patient population, have been so great. We haven't had the capacity to admit patients for symptom interruption. But the other reason, though it's not an admission criteria, I would say that if you're concerned about a patient's increased purging activity multiple times a day, then that would be another reason to give us a call and ask about whether they need to be admitted or assessed.
If you don't know, call.
So just a note about associated mental health concerns, because as we know, there's common comorbidities between all eating disorders and other mental health issues. OSMH is not the regional mental health center, as you probably know, that's RVH. And we don't have a pediatric psychiatrist available for an in-person consult. We have one that we can talk to and consult via virtual care or via telephone for sort of less acute issues. But for example, we don't really have the capacity to keep a Form 1 patient, any significant active suicidality or self-harming patient or active psychosis. We're not the right place for that. We don't have the right resources. So if the patient is medically stable and your primary, if the patient has an eating disorder, but they're medically stable and your primary concern is one of those things, suicidality, self-harm, psychosis, that kind of thing, then RVH would be the right location for them. If the patient, however, that being said, if the patient is medically unstable, we will still take them, and we have.
Code blue, all clear, day surgery. Code blue, all clear, day surgery. Code blue, all clear, day surgery.
But that means, so we will take a patient who's medically unstable, who has these mental health concerns, but you might want to consider whether RVH might be the more appropriate location if those are very active, because it's easier than transferring the patient after they become medically stable. So for non-urgent concurrent mental health concerns, if you're referring a patient in the outpatient setting, then we want to remind you to refer them both to our eating disorder program as well as to the appropriate medical practitioner. So for example, a pediatrician or a psychiatrist. So the eating disorder program is, as we've sort of identified, a really specialized team. And your typical psychiatrist, counselor, registered dietitian doesn't necessarily have the skills, and we'll get into that a bit later, but we just want to remind you that 2 referrals in this case are appropriate. So for example, if you have a patient who has really significant depression and an eating disorder, by all means refer them to either a pediatrician or psychiatrist, and also to the eating disorder program.
And of note, I actually do work at both RVH and OSMH for eating disorders. So if you're ever unsure too, I do know both programs because I work in both programs.
So I just have a flow chart here just to sort of go through what you would do for a patient who you have a concern for an eating disorder about and where you could send them. So if you have a patient, you're concerned they have an eating disorder, the first question is, are they medically stable based on those criteria? If they are not medically stable, automatically you're calling the pediatrician on call, either at OSMH or RVH, depending on where the patient lives. If they are medically stable, then the next question is, do they have any acute mental health concerns requiring admission? So suicidality, psychosis, that kind of thing. If they do, then you're calling RVH for a mental health admission. If they don't, If they have non-urgent mental health concerns, in addition to their eating disorder, then you're referring to our eating disorder program, as well as to a medical practitioner if needed, if you don't feel comfortable managing those mental health concerns on your own. I should say, I know many primary care providers are very comfortable managing anxiety and depression. If there is no non-urgent mental health concerns associated, or they think the eating disorder is really the primary concern, then just refer to our outpatient program. And our nurse practitioners, Andrea and her colleagues at RVH, are also able to manage minor, sort of, not, I shouldn't say minor, but more typical, straightforward mental health concerns like anxiety and depression. So I think I'm going to talk about this, but I'm going to let Anthony talk about this.
So our eating disorder program is a multidisciplinary team made up of myself, the nurse practitioner, for the medical management of the program, as well as our eating disorder counselor who has specialized eating disorder training, and our registered dietitian who has specialized training in eating disorders. We know best outcomes, and like as Dr. Sommer said, the only thing we can actually say is evidence-based practice is that best outcomes are with this model. So with a multidisciplinary model focusing on family-based therapy. Frequency of appointments is determined by severity of illness and risk. So if a child has just been discharged from hospital, for instance, we were talking about this today, we usually see them for about 1 to 2 months every week, and then slowly progress out of that. And the reason for that is even once they're stabilizing, we then have to introduce activity back, and we have to introduce all these different things back, and we need to make sure we're not going to end up backwards. Triaging process is currently in effect, so we've done a lot to do this significant wait list. We do not do a first come, first serve. Unfortunately, we wish we could. So do we have kids that have been waiting a year? Yeah, we do. We do. But that doesn't mean that we haven't said anything to their practitioners. We have tried now to send notes back to every practitioner of what to watch for. We've sent out update letters saying, hey, if you could please update with some information so that we can better appropriately triage. The good thing is that with our amazing pediatrician team here, we have come up with a plan where I get the intakes, I look at them, I decide whether they're urgent, non-urgent, as far as the information you're giving us. Then Dr. Sommers and I sit together, we kind of go over a plan, and our goal is to get through our wait list over the next couple of months. We've actually gotten through quite a few since the pediatrician started taking in some intakes. What does that mean? That means that they're getting a medical assessment by one of our pediatricians to determine whether they are stable or not. It does not mean that they're in the eating disorder program.
And it does not mean that they come off the wait list. I should identify that. So if you have referred a child to the eating disorder program and they've been seen by a pediatrician, it means we've assessed them and sort of helped to further triage the severity and urgency with which they need to see the eating disorder team. But they unless we think that things are going really well, the patient's in recovery, they have outside supports, we're still leaving them on the wait list, and they will still see the eating disorder team.
So what happens is you will see that when the pediatrician sends you back a note, it will also have the eating disorder team on it, or myself. And then that way I've created a file for them, and we have this lovely big triaging chart where we're trying to put dates in for these kids. And we have constant communication once they've been seen by the pediatrician. And there is always evidence back to you of what we need from you to continue to do until there. And we are going to talk about that. So just kind of a nice little picture for you. It is not just about the eating disorder team. The patient and family is the center of our care. You have your eating disorder team kind of on the right side of the circle, but then we also really do depend on our community supports. I have a lovely nurse practitioner actually in Perry Sound who shares care with me with one of our patients. And this was due to barriers of traveling. And so what happens is I created a sheet, she fills in the sheet and gives me the vital signs and everything and where we're at, any other points that she needs me to know, sends it to me. And then the next time I see the patient, I can go by their information and mine, but I can also call them in between if I need to based on their information. Registered dietitians in the community are very supportive and helpful, and we just have to be a little careful with that. Our ask is that the registered dietitians don't meet with the patient, that they're meeting with the parents, which follows family-based therapy. So we shouldn't be talking about food with the eating disorder. We shouldn't be negotiating about food with the eating disorder, and the eating disorder shouldn't be in charge of food. So when we're using registered dietitians in the community, if you're concerned it's an eating disorder, please do not send the child, send the family. And school supports. We actually have a mental health and addictions nurse that we will refer to often if there is comorbid mental health. We really communicate with the guidance counselors because a lot of our kids have to eat with the guidance counselors for a while. So we have pretty good connections up there as far as our community supports.
So how to refer a patient to our program? So we have a specific referral template, and if you contact our team, we'll send that to you. Or if you want, we can, I don't know if we can arrange with Kathy to have it. If you guys want it, we can send it along. It's really important that that referral template is used, because we do need all the information that's noted on it in order to make a proper assessment and properly triage patients by severity of severity of condition. We really appreciate it if you can include all the growth charts or growth data that you have. One point, like Andrea said, is not enough for us to make an assessment of where the patient is and where they should be and how that's changed over time. And growth charts are what help us determine a progress weight or an ideal body weight. So whatever data you have about growth, please send it along. When you do send in your referral, we will notify you whether the referral has been accepted or declined, and if so, why. We'll also notify you if any additional information is required. So for example, if you send your referral in and it's missing an ECG, which is something we ask for, then we ask that you send it within a month of the initial referral. And we're not trying to be harsh here. We want everyone to get the services they need. And, obviously we make exceptions, and we're not super hard and fast about this, but if the referral isn't complete, we, like Andrea said, we have to just turn some down, because we just don't feel like we can safely triage them and safely keep the patients on the wait list without enough information. So some common referral pitfalls, we already alluded to a lot of these, but not using the referral template is a common one. And we know that a lot of people just don't know that it's out there.
And we updated it. We made it easier.
Yeah. So we do have patients who are sent in without a current weight or a highest weight. The highest weight is a really important thing if you have it available. If not available, just write, it's not available. We don't know what the highest weight was, but you can even include an estimated highest weight. A lot of the time, the patient will be able to tell you what their highest weight was,
especially in eating disorder.
Yeah. Orthostatic vital signs. So like we talked about, orthostatics are really important. They're one of our admission criteria. They're a better assessment of heart function and vascular health than just a spot blood pressure or a spot heart rate. And that's why they're so important. So please, if you're doing vitals, try to remember to do orthostatics, and we may send it back and ask for them for additional help. Missing investigations, missing historical growth information. And then the last one is so we do get referrals for binge eating disorder, and that's actually not under the scope of our clinic, unfortunately.
But you can send it to, if they are binge eating, so binge eating only, there's no purging, there's none of that, it's binge eating disorder and they are obese, that is our chat program.
Right.
So you can refer binge eating disorder, straight up binge eating disorder, to our chat program. But if you send them to our eating disorder program, we're going to send back and tell you to go to chat, because we don't actually cover binge eating within the eating disorder team.
Right. And so chat, if you don't know, stands for Choosing Healthy Actions Together. And that's our obesity management clinic here at OSMH, which is also a multidisciplinary clinic. It's just that there's different issues, medical issues that go along with binge eating disorder. So that's why they're separate. Okay, so interim management. So like we alluded to, our wait list is pretty long. And so we want to help you know what to do while you're waiting for your patient to be seen by us. So at minimum, we ask you to see the patient monthly, ideally seeing the patient bi-weekly. We know that this is really challenging for primary care providers, as your patient load is so high, but it is really important. What we need on those visits, or what is the recommended at those visits, is that minimum they should be in person. We need the orthostatic vitals, a blind weight, if you can assess their symptom behavior severity. So for example, purging frequency, and a safety assessment. So suicidality, self-harm. Obviously the frequency should be increased based on how severe their symptoms are and how close they are to medical instability. And we love updates. When you see a patient, if you want to forward your note from the visit, please, we would love that. Every time you do an assessment, we're happy to get that update. More updates is better than no updates. We like to know where the patients are and see what their trajectory is, because a patient that's trending closer and closer to medical instability, we will get them in to be seen much more quickly.
Okay, so while on the wait list, a couple of things that you can start supporting in the community. And this is what I do. Sometimes I'm bringing in the kids off the wait list without the rest of the team seeing them, just because we know they're close to admission standards. So first thing is removing all scales from the house. And so parents are like, oh no, they're in my bathroom.
Or they're locked up in a closet.
They're locked up in a closet. These kids can get them. And so it is removing them, like we're right out of the house. If they are getting to the point where they are querying whether or not this kid is going to be meeting admission soon, decrease activity level. Or even if you understand that they're doing like 3 hours of exercising a day, start decreasing it just right away. As long as they're not severely restricting. So if they're, 1,000 calories or more a day, I probably would be fine to say, start the 3 meals, the 3 snacks, which is mechanical meal plan for eating disorders. And they should be supervised. So the parents should be making the food, serving the food. They know how to feed their kids. They've done it before. So they serve. The child should not be in the kitchen. If the child is baking with them, the child has to eat the baking. And then for 30 minutes after eating, someone should be with them too, to prevent any purging or excessive exercising the food off. And then some nutritional supplements. You may have noticed if you've referred to us that we always put these kids onto vitamin D, 1,000 international units PO daily, and calcium carbonate, 500 to 1,000 milligrams PO daily for bone health. As well as we know that a lot of our kids will get low ferritin secondary to malnutrition and dietary insufficiency. And although they're not an anemia, we know that they just don't have the stores in place to actually bring up their iron, and they can start to get more and more symptoms. So if the ferritin is less than 20, we do treat with 3 to 6 milligrams of elemental iron PO daily to a maximum of 200 milligrams a day. So again, food is medicine, and we know that, but it can also be the greatest source of fear and the greatest source of distress within the family. Food becomes everything in that family. Again, community dietitians, please meet with the parents, not the patient. You can have them having counselors for concurrent mental health issues, New Path, Kinark, Waypoint, even the mental health and addictions nurse at school. I've had lots of great reviews from our patients. Some of our top resources is NEDIC, which is the National Eating Disorder Information Center. We also have the Kelty Eating Disorders, where parents can learn how to feed their child in an eating disorder mechanical meal way. So they have videos that show them the proper terminology to use, how to push through when they don't want to push through. And then there's Change Creates Change, and I've actually spoken to them on multiple occasions and made a relationship with them as well. Change Creates Change is there to support with psychologists and registered dietitians until such time as they are picked up by an eating disorder team, and then they transfer care. They will not take once they're into a team. Another just really quick point about community access is I've also made a really good relationship with our RVH mental health, pediatric mental health, child and youth, because we were having so many kids going there. And so they are getting better too at when we have a kid who's admitted there, they will reach out to us if they know the child has an eating disorder to get some guidance on meals and stuff.
I'll just add about the Celtic eating disorders. If you have any interest in eating disorders and you want to learn more about what it looks like to manage an eating disorder, the videos are excellent and the resources are excellent. Also, we talked a bit briefly before about how language is so important in eating disorders, and the Kelty videos really model that well and explain a bit about why it's important. You've probably heard Andrea say the eating disorder is negotiating, the eating disorder is doing this, and one of the things that you should know is that when we're managing eating disorders, the eating disorder is its own entity, separate.
It's the bully.
Yeah, it's the bully separate from the child. So it's not the child who's not wanting to eat. It's not the child who's throwing out food or yelling at their parents because they're frustrated. The eating disorder is doing that. And so that's, if you hear us using that terminology, that's what that's all about. And that's a fairly standard way to refer to eating disorders, and probably the standard way to talk about them.
You'll hear a lot of them say ED.
Yeah.
So we name it ED. Some of them will name their eating disorder something else. And it's not a personality thing. It's literally, we try to teach them that there's the child and the eating disorder. One other thing actually that just came up with terminology is one of the things that has happened once or twice, and it's totally innocent, but in an eating disorder's head, it's not. We will treat this kid, they'll go into hospital, they'll be with us, they'll go back to their family physician or something for a checkup or something else, and they'll be like, you look so good, look at all the weight you've gained, you really look filled out now.
You look healthy.
Or looking healthy is okay. We actually say, you can say, oh, you look so healthy.
Okay.
You can say look healthy, but please don't tell them, oh, you look so much better, you don't look like skin and bones anymore, or something like that, because that can totally trigger and set them back and relapse them.
So the Kelty site is good for some of those things, and knowing a bit more how to talk to kids with eating disorders. Okay, so I'm gonna go through a case study, and we're almost done. Oh, I think we're over time, Kathy. Should I keep?
That's okay. Yeah, people leave if they have.
Okay.
They have to.
Okay, so we'll keep going. So this is a patient who we admitted recently, and she's a good example of eating disorders during the pandemic, I would say. So she's a 13-year-old female, which is on the younger end. She has a past history of Tourette's, ADHD, OCD, and anxiety, though it seemed at the time that none of them were particularly active, but that turned out not to be entirely true. At the time of referral, she had only a 2-month history of restricting intake, which is a little bit atypical. As Andrea said, usually it's about a year, but she'd lost 25 pounds in that period of time, which is really, really significant. She was on our wait list, but she had a very significant restriction, eating less than 500 calories a day. So her mother had called the team and brought her into Emerge to be assessed. When we spoke with her, she described a lot of feelings of guilt and feeling like she was more in control when she's losing weight. There was a triggering event, as often there is, but it's not always, and it's sometimes described as a triggering event, but maybe it wasn't that significant. So she describes she had this episode where she ate lasagna, she put on a pair of sweatpants, they didn't fit, she went and weighed herself and immediately felt like she had to lose weight and started exercising. This child is a good example of a child engaging in exercise during the pandemic. So she had started a YouTube exercise video series and was doing that every single day until she did that every day for a week, but she was finding that with doing that and restricting, she couldn't stand up and she was getting black spots in her vision. So she needed to do something less intense. Interestingly, this specific YouTube video series it's by a YouTube creator called Chloe Ting. It has been a commonality in a number of our eating disorder patients over the last year. We are not sure what about this particular series seems to speak to the eating disorder or speak to these kind of children who are susceptible, but there've been a number of patients who have been engaged with this, and it's been their main source of exercise. There's all these.
She shred the body in 2 weeks and do 10-minute workouts every day. So they don't even have to do a 30-minute workout, but then she also does like this whole dietary component, not taking into account all the different ages. This lady is in her 30s, but looks like she's 18.
Yeah. So it's interesting how these trends come and go. And this is a good example of this has been the trend. And we don't know, so often there's, like we were talking about earlier, there's TikTok videos, there's pro-Ana sites, there's all sorts of sources of information that wax and wane in popularity. And this has somehow come up in one of these things.
A lot of these kids will also do exercises in bed so that they can't be seen. So sit-ups and planks and everything in their bed.
Yeah, so after she stopped doing these videos because they were too intense for her, she would do a 30-minute exercise video. She was doing often 1,000 jumping jacks a day, plus or minus push-ups, and would exercise to burn off anything she ate above 500 calories a day. Her goal was 500 calories a day. As Andrea said, a good way to estimate is asking what percent of their previous intake, and this child was taking about 25% of what she was previously taking, and had a goal weight of being under 97 pounds, which is entirely unrealistic for this child, and we'll go into her actual weight and things like that later. So some of the eating disorder behaviors that she really exemplified that are really common amongst other children with eating disorders are this really intense fear of gaining weight, both in terms of how it would change her body, but also because it would mean that she had lost control over things, and control is a huge component of eating disorders. She had a lot of very typical fear foods, which are foods that patients adamantly avoid. So pasta, baked goods, cake, things with carbs.
But they'll bake for other people so that they can watch them eat.
So they often enjoy baking and will bake for other people, or if they are going to eat these things, they're often modifying the ingredients in a sort of quote unquote healthy way, like substituting for almond milk or substituting bananas for eggs and all these kind of things that sort of healthify these baked goods. Her parents had been supervising her, but she started throwing out and hiding her food. Interestingly, on her admission, She told Andrea how few calories she was eating, and her mom said, no, there's no way I watch her eat every single day. And then this child disclosed that she said, no, I know mom watches me, but I wrap my food in a napkin, I put it in the garbage, I put it under other things in the garbage so that she doesn't see.
She would wipe her napkin across her mouth and spit it out.
Yeah, making dirty dishes to make it seem like she had eaten. So eating disorders are really smart and really manipulative. And this child, like Andrea said, when they're more malnourished, they're more likely to reveal these things. And she disclosed all these behaviors to us. She was drinking sparkling water instead of meals, which is a good example of eating a volume eating, or I shouldn't even say eating, just filling up the stomach with something to make you feel less hungry, but also of water loading. Her parents had hid her scale, but she found it and resumed weighing herself. She had a practice of recording. She would take body measurements, and she would also record all her caloric intake every day on a little scrap of paper that she kept in her sock during the day. And then at the end of the day, she would put that in a box in her room and was keeping all of these notes in this box in her room.
We actually found some of those after she was discharged too, and I had to stop it again.
So quite intense eating disorder behaviors, but I would say these behaviors are not uncommon amongst eating disorders. She had all of the symptoms of malnutrition that we talked about previously. Constipation isn't something we talked about, but it's very common. She did have secondary amenorrhea ever since she started restricting, but at that time there was no binging, purging, or laxatives, just the excessive exercise. So in terms of a relevant family or social history, she does fit the sort of the mold for eating disorders. There was a history of anxiety, both in her immediate and her extended family and multiple members. She was in grade 8. She was very high achieving, 90 to 100% in all subjects, a competitive dancer, doing dance 2 to 3 times a week. But that was about it. So at the time we saw her weight was 46.4 kilograms, and that was down 10.7% from her highest weight. So she was at 81% of her progress weight, but if you look at that, she lost almost 20% of her body weight, which is a huge amount. We were very concerned. Her BMI was 17.9. She had a heart rate change of 32, and her heart rate was less than 50, and that was confirmed on ECG. She had significant pre-syncopal symptoms with standing, though she denied it at the time, and her skin was very dry and pale. ECG showed signs of bradycardia. Now the QTC is something we look at. Prolonged QT is a common arrhythmia we see associated with electrolyte disorders. She had a low T4 but a normal TSH and a mild leukopenia, which are all commonly seen in malnutrition, sort of like a sick thyroid syndrome, but that wasn't felt to be too significant. Otherwise, her blood work was normal from an electrolyte perspective. Urinalysis showed elevated specific gravity, trace ketones, and some bilirubin, which just indicated mild dehydration.
Something really important to point out, if you see that low T4 and normal TSH and you really think that this is in the picture of an eating disorder, please do not go ahead and treat the thyroid. We've had some kids who've been treated for thyroid, and that actually makes them way worse.
So this child was diagnosed with anorexia nervosa, restricting subtype, and admitted to our unit based on that heart rate. We started a refeeding protocol. We pretty much start everyone at 1,500 kilocalories a day and increase by 250 a day, unless they're taking in less than 1,000, or even sometimes we do. It depends on it depends, but usually we start at 1,500.
We've had a couple recently who've been 1,250, but for the most part, 1,500 is what most of the anecdotal research out there does support.
Yeah. And we do refeeding blood work every day, daily, for 5 days. And that the main disturbances we see, as you would with refeeding, are hypophosphatemia, hypoglycemia, hypomagnesemia. Yeah. They start 3 meals and 3 snacks. Initially, meals are supervised and supported by our pediatric nurses, who now have had some training in meal support. This is twofold. One, they have more experience than parents to give parents, or I should say threefold, to give parents a bit of a break because parents have been dealing with this for a long time and are exhausted. And three, often children will disclose important information to nurses that they aren't comfortable talking to their parents.
And nurses will pick up behaviors,
Yeah.
so watching too.
Yeah. She's on bed rest, which almost all our patients are when they're admitted, with constant monitoring. And initially, she was one of those children whose vital signs did become more unstable after a few days in the hospital. She ended up going on to require NG feeding support because she had such strong feelings of satiety and such strong eating disorder thoughts. So after 3 weeks, she was still having really strong ongoing eating disorder thoughts and behaviors, a lot of guilt around intake. Meals would take forever. That's another common eating disorder tactic and behavior, taking a long time to eat meals, eating very small bites. Other things that we see are like over seasoning or over salting to ruin foods, that kind of thing. So
Spreading them out,
playing with food around the plate. So meals were taking forever, and we were still needing an NG tube to help feed her.
Can I step in there
Yep.
for a second? So just sorry, with the meal times, we do have a rule, and even when they go home, it's 30 minutes for meals, 15 minutes for snacks. If they don't finish within that time, they drink an Ensure instead. And the reason for that is if they push it out, then they're moving into their next meals and the eating disorder is winning. So there's no compromise with that. And that's when the NG tube then starts to be considered too. If they refuse the food or they can't finish it and they can't finish the Ensure, then the NG tube goes in to make that replacement happen.
Yeah. Another thing we do when patients come into the hospital to add to that is any dietary restrictions that were initiated during the eating disorder are not allowed to continue. So if a child's been a vegan their whole life, we are not going to make them eat meat or eat dairy or animal products. But if a child has gone vegan during the time of the eating disorder, that is typically reversed, similar with gluten-free, dairy-free, that kind of thing. For this patient, because she was having such strong thoughts, which were really preventing her intake, we started her on olanzapine, which has good evidence for use in eating disorders. Number one, it really helps quiet those eating disorder thoughts. Number two, it stimulates appetite. So this patient responded incredibly well to this. She had a rapid improvement over the next 3 days, and I saw her about after a few days, and she had her NG tube out for over 24 hours and was eating all of her food and told me, I can't hear the thoughts anymore, which was amazing. So she had a total length of stay on our unit of 29 days, which I would say is not uncommon and probably around typical. I don't know what you know what our
That's
average.
typical.
Yeah.
Our average recently has been less, but we are realizing that with the less, they've been getting readmitted more. So on average, usually it's about a month that
Yeah.
they stay.
Yeah. And when she was discharged, her weight was 53 kilograms, which was 93% of what we determined her progress weight to be. And I'll let Andrea talk about what happened after.
So what happened after, we saw her 1 week post-discharge and she actually had gained 2 kilograms, and we actually thought she was fluid overloading because it's very uncommon for them to gain weight when they leave. We usually expect them to lose a little bit initially because they have more activity just unintentionally at home. So she gained 2 kilograms, but the thing with this kid is that the parents were so on board and so engaged and so supported and so well resourced that they followed family-based therapy to the T. And that is why this child has done so well. She's not relapsed. She has not gone down again. Like, there's no slips. There was some hiding and throwing out food initially when she got home. There was some hiding the notes in her socks, because I never tell the kids when I'm going to take their socks off, when I'm going to leave them on, when I'm going to put them in a gown, when I'm going to leave it on, because I like to be able to catch even self-harming is how I catch it sometimes. And so she does sit there a lot. She'll still sit there and she body checks and she covers her abdomen. Body checking is just seeing, like, can I fit my finger around, or how much do I need,
Or can I pinch a certain
can I
amount
pinch an area that I never used to be able to. Triggers were definitely her clothes. So something that we usually do with the families is talk about clothes, anything that was like during high season of eating disorder, get rid of, making sure that they have clothes that will fit. And dance, when she went back to dance, she had a huge trigger and kind of relapsed a bit with that, but still, because of the family and how on the ball they were, such a steady weight gain, and she's been doing really well. Just another aside with that, if you have a parent who has an eating disorder or issues within the family doing family-based therapy, it's not for everyone. And if a parent has an eating disorder, it's not going to work. So I do have a child who's probably, her prognosis is not great. about the same age, but the difference is that her mom has an active eating disorder and is not doing so well herself. And the child has actually attempted suicide twice in the last 6 months. So just an idea, because suicide and cardiac are the top 2 reasons that our eating disorder population die, remembering that that mortality and morbidity rate is greater than 20% for a kid with eating disorders that's not being treated. Older adolescent presentation, just something, I'm not going to go into a whole case study because we knew we didn't have time for that, but just some notes. Even when they are malnourished, our older kids have more of that frontal precortex all figured out. So they are better at lying. And a perfect example is our 16, 17-year-olds when they come in are absolutely straight faced. No, I'm not. I don't care how my body looks. I don't care about this. I don't care about that. You're wrong. I don't have an eating disorder. This is just who I am. Very adamant. The difference is that once we start telling them, okay, well then if you have no issues, then 3 meals and 3 snacks a day should be no problem for you. And that is a problem. And when that comes out, it will always come out, but usually it takes more time to suss out the eating disorder language in an adolescent who's older versus a young adolescent.
So in summary, eating disorders have become 3 to 5 times more common during COVID for a variety of reasons directly related to what's going on during COVID and all throughout the world. Anorexia, ARFID, and OSFED are the most common in children. And as a primary care provider, the role is to identify the red flags, make the appropriate referrals, and monitor the child to maintain safety and update us so that we can get them into the program when appropriate and as soon as possible. Key first step in any assessment and monitoring is ensuring medical stability. And the specialized multidisciplinary team and family-based therapy are the gold standard and associated with best outcomes. So they always need to be referred to an eating disorder program. And if there's any questions, we, as the pediatrician on call or the eating disorder team, are always available to answer them and happy to do so. So don't hesitate. We worry about these kids a lot, so we're always happy to get questions and help you out. So thanks so much for listening. I know we went quite over time, so apologize for that. But if there's any questions, we're happy to take them now.
We're pretty passionate about this population.
If anyone has a question, you can just unmute yourself and ask. I'm wondering what the success rate is of this program long-term. Like how many of them successfully do away with the eating disorder?
Right. So eating disorders, unfortunately, aren't like other diseases where there's a full recovery to the extent that they always will have some thoughts in the back of their head. They'll always have that bit of struggle with the body image and everything. But a lot of our kids do very well if they do follow family-based therapy, and the prognosis is usually pretty good, and they do go on to live lives. We've seen some of them become nurses, some of them have kids now,
Child and youth workers,
social workers. So they actually do quite well. And because of they're usually people pleasers, and they're also usually really good at school. So they do actually become these amazing young people that thrive if they get to the contemplative. We do have some kids who always sit in the pre-contemplative, especially if the parents aren't on board and the parents support, oh no, they're not really, or they're orthorexia, or they're this, or they're that. Or we just have parents who initially are on board, but then are like, okay, well, this is interrupting our lives too much. So we're good enough, we're gonna go now. And then, like I said, parents who just can't follow family-based because they have their own mental health or their own whatever else is going on. Usually their prognosis is not as ideal. Some of them, like I said, there is a 20%. That was pre-COVID. It was 20% morbidity mortality rate, probably much higher now.
Thank you.
It is a total shock to the family. One of the family members usually has to go on a leave from work. They have to stay home 24/7, watch, like they cannot leave their kids alone. We take doors off of bedrooms sometimes. We have to get the parents to sit in the bathroom with them. I have one kid who, honestly, I thought this kid was going to die because it's a really poor prognosis too if they go from restrictive to binge purge. So if they're switching back and forth between the types. And this one young lady I had, I've been with her for about 1.5 years now, and she started out, I'd never seen someone so sick. She would hide her gummy vitamins in her sock because they were too many calories. And I admitted her 5 times. 2 of those times transferred her to sick kids, brought her back, admitted her to Ontario Shores. And like, she's gone through everything. And finally, a year and a half later, I got a message from mom literally 2 days ago saying, I couldn't be home after school. Her friend came over and she made them bagels with cream cheese and blah, blah, blah. This was huge. This is a kid who hasn't been able to be left alone. I have done sutures on this kid's leg from self-harming, from the eating disorder thoughts, next level. And we finally are making progress.
I just had a question about transition to adult care. So if you're following like the 17 years, 6 months, close to their 18th birthday, do you have an adult transition program?
Unfortunately, we do not. So we're hoping on the horizon to not only have an adult, like a transitional youth program, but also to have a full-time pediatric program here. But unfortunately, it is a big red flag. You are absolutely correct. And so what we usually try to do is arm them to be prepared, or if they're in our program at 17, we'll send them referral at 17 because it usually takes about a year to get into an adult program. So if you have someone who you're identifying early on at 17, you should be referring them to the adult programs. Unfortunately, the adult programs are in UHN, Trillium. There is a transitional care program at South Lake. But I'll be honest, everywhere's full all the time lately. So the earlier you can get that referral out, the better. And then just arming yourself with the knowledge of what's admission versus not admission. But again, adult criteria and when they get admitted as an adult is a lot different. Sure, not the answer you wanted to hear.
Yeah, I know our wait list in Sudbury is about 2 years right now.
Yeah, I believe it. Actually, I know the NP in Sudbury too, so I believe it.
Any other questions?
We're always happy to field them later on if
Yeah.
you get one later, or if you had to go right now, we understand.
Send us an email, happy to just answer questions.
And we can
anytime.
send our email. Kathy, you have our email,
Yeah.
so you can share our email.
Okay, thank you.
Well, mine.
Yeah, you can also
Okay.
share mine.
I shouldn't be donating Dr. Sommer's email.
You can
without
share
asking.
my email. As long as it's not with patients.
Yes.
All right. Thanks very much for listening, everybody. Really appreciate it.
Thank
Look
you so
forward to
much.
working with you.
Yeah. Anytime you have questions, please reach out. We're more than happy to chat.
Thank you so much for presenting. I know I learned a lot today from this, so,
Good. That's great.
all right. Have a good day.
Have a great day.
Bye.
Merry Christmas, everyone.
Merry Christmas.